Welcome, everyone, to the lectures for the second week of our course. We're going to begin with a lecture which is a continuation of last week's lecture. And as I said before, this was originally recorded as part of a lecture on primary health care from the course I teach here at Johns Hopkins on Introduction to International Health. And so this section B of that initial lecture in Introduction to International Health is called What is Primary Health Care? So it's an attempt to describe in some depth the concept of primary health care as it has come to be understood in the field of global health. And then following this lecture, we're going to have a very special experience by listening to Carl Taylor and a lecture that he recorded prior to his death, which is his own definition of primary health care as well and what he considers to be the roots of primary health care. So we hope you enjoy this. The term primary health care in reality means many things to many different people. Some of the meanings of this word primary health care are derived on the term primary. Primary health care has really two parts. One is the term primary, the other is the term health care. But by primary, to some people it means first contact with the health system, which is certainly understandable. Some people refer to it as meaning basic, very elementary, the very fundamentals of health care. And this leads some people to sometimes say that this basic health care is poor quality health care, inadequate health care, and therefore isn't really appropriate if we're looking for a high quality standard for people around the world. Some people refer to the word primary as meaning essential. In that sense, I think we could think of some activities that are not commonly thought of as primary health care to be primary health care. And in that sense, essential and emergency surgery, I think, could very easily be thought of as a part of primary health care. And increasingly, people are using that concept of basic and essential surgery as needing to be considered as a part of primary health care. And then there's the sense of primary as meaning first causes, and by that I mean the multi-sectoral influences on health that go far beyond medical care. We're talking about education, nutrition, water and sanitation, among other things. And then we have this trouble understanding what we mean by health care, the dilemma between preventive and curative services, the biomedical disease orientation in which the patient is the passive recipient of medical services versus the concept of creating conditions and environments that are healthy or that promote health, very different kinds of concepts. And then, as I mentioned before as well, health is a social phenomenon whose determinants cannot be neatly separated from other social and economic determinants. And then the whole behavioral side of health, the importance of programs to promote healthy behaviors is certainly a fundamental part of healthcare, but it's not commonly thought of as part of the healthcare process so much in developed countries, but is clearly important in very poor countries. So we have this issue in which I think for many people, primary health care is what I call an ambiguous mental model. It's the unconscious concepts that flow around a set of words that we're not always well aware of. One of the interesting parts of all of this to me is the concept of the household production of health, which isn't widely recognized, but it's the basic notion that mothers are the most important health care providers in the world because of the influence that they have on the health of their children, which is very much a alma mater kind of concept and opposed to the idea that it's health systems and doctors and hospitals that produce health. And then there's this whole new flow of activities and ideas that flow around community-based primary health care that I'll get to in a minute as well. Activities that take place outside of health facilities with strong engagement of the communities. I like this slide that came from an article by a friend of mine, Jack Bryant, in which primary health care is such a fundamental part of health systems thinking. But unfortunately, for a lot of people involved in health systems, they don't really see primary health care as a fundamental, basic element of what a health system should be. This is a set of diagrams that I put together myself when I was living in Bangladesh that I think helps me in my thinking about the way we can conceptualize where primary health care fits into the healthcare model. In the top, we have on the left the various levels of curative medical services from primary care to secondary care and tertiary care. And the term primary care there is more the medical notion of it. But then we have public health services to the right, which have a continuum going from community-oriented to services-oriented to disease-oriented. And as you move towards the center on this diagram, we have an increasing emphasis on community-oriented approaches and responsiveness to local community health needs. And that general approach is shown also in the bottom, but not from the medical side as much as it is to the more intersectoral approach to improving health, thinking about centralized top-down approaches to the left to more decentralized bottom-up approaches towards the center in a similar kind of philosophical way, but not quite as medically oriented. When I lived in Bangladesh, I wrote a book, which I'm very proud of, called Health for All in Bangladesh, Lessons in Primary Healthcare for the 21st Century. I was able to track down a fairly accurate notion of where the government expenditures for health went. And you can see that in Bangladesh at that time, in the late 1990s, they spent less than 20% of their budget on primary health care and approximately 2/3 of it on hospital care. I think this is typical for many developing countries in which primary health care has not been the major focus of funding, although many would argue that it's got the greatest potential for improving health. In terms of personal expenditures for health, you see that in Bangladesh, again similar to so many different developing countries, the overwhelming proportion of the small amount of money that's spent on healthcare is given directly to drug retail outlets for purchases for drugs over the counter. Very small amounts of money for other activities. This is the annual World Health Report from 2008 that I mentioned earlier, which promoted primary health care. And the Lancet series on Al-Mata that was published in 2008 as well, both in part recognizing the importance of Al-Mata and the growing recognition of the need to give more attention to the concepts at Al-Mata. I wanted to get into a little bit of detail about exactly how Al-Mata defined primary health care, but I also want to focus briefly on some of the other variations of primary health care, as you see on this slide: community-based primary health care, what I call CBIO, census-based impact-oriented approach, care groups and participatory women's groups, and community-oriented primary health care. The Declaration of Al-Mata considered primary health care to be essential health care based on practical, scientifically sound, and socially acceptable methods and technology, made universally accessible to individuals and families in the community through their full participation and at a cost that the community and country can afford. So in that sense, primary health care addresses the main problems of the community. It includes promotive, preventive, curative, and rehabilitative services, so it certainly has the curative element built into it, but within the context of a whole range of broader activities. But it has this intersectoral element that's lacking from the biomedical model. Specifically talks about the importance of food supply and nutrition, safe water, basic sanitation, maternal and child health, family planning, the public health approach of prevention and control of locally endemic diseases, treatment of common diseases and injuries, which is a priority for local people, and provision of essential drugs. Again, a local priority, but not necessarily a disease control priority. But it talks about these other sectors: agriculture, animal husbandry, food, education, and housing. And it also gives great importance to engagement with the community, maximum community and individual self-reliance, and participation in planning, organization, operation, and control of primary health care. Again, This is an example of the challenge to the more traditional medical model. The Declaration of Alma-Ata goes on to say that these primary health care services need to be sustained and integrated into a functional and mutually supportive referral system. So it recognizes the need for hospital care, surgical services, and the need for comprehensive care. But of course, it also states that we need to create services that countries themselves can afford. And it talks about the various levels of workers that are required to make primary health care work, all the way down to community workers, as well as traditional practitioners. Again, a challenge to the modern medical model, so to speak. But the creation of a health team in order to be able to respond to the health needs of communities, particularly when resources are limited. So many people have referred to the three pillars of Alma-Ata, which are embedded in this definition: equity, community participation, and intersectoral development. Again, very different concepts from the medical model and from the notion of primary medical care. I want to say a few words about community-based primary health care, because this is becoming such an important new direction for primary health care. Of course, it was very much a part of the Alma-Ata concept, but the success of this and the enthusiasm for it now is becoming quite exciting. And so I wanted to say a few words about this. Again, community-based is a term that means different things to different people. And when I think of it and I talk about it, I'm talking about services that take place outside of health facilities. But in the eyes and the ears and the mind of many other people, they're thinking about services in which local people are engaged, in which they're readily accessible, but they still could be facility-based services. But that's not my concept of community-based primary health care. I'm not saying that I'm right and they're wrong, but it's important to be clear what we're talking about. So through this approach, we're talking about provision of important services outside of facilities, which again was part of the Naringwal Project. They were one of the early pioneers in this. But we're also talking about education and health promotion at the household level, which is a fundamental part of CBPHC. So you see here, this is a definition that I was involved in developing that's very long and laborious, but it tries to, as clearly as possible, define what we mean by CBPHC. And we did this because we were developing a review of the effectiveness of community-based primary health care and improving child health. And so we needed to define what kinds of programs and documents qualified for our review and which ones didn't. And so I won't read this to you, but it gives you a sense of the effort that we took to clearly define what community-based primary health care really is. But when you boil all this down, it basically involves any activity that takes place outside of a health facility that's focused towards improving health. It could be a very narrowly focused vertical activity, or it could be a more comprehensive approach, and it could have a connection to a health facility, but it didn't have to. And so that's the basis for what our review was all about. There's an interesting story about integrated management of childhood illness and how that links to primary health care. But this started out as being almost entirely focused on facilities and became a community-based activity because of the lack of effectiveness of simply limiting this to facility-based services. It's very interesting that back in the late 80s and much of the 90s, IMCI was the major focus of WHO's activities and, to a lesser degree, UNICEF in improving child health. And it underwent a very rigorous evaluation. And because of its facility orientation, it was shown to have no impact at all on mortality. And part of the reason for this is the limitation of health facilities and the lack of access that people have to health facilities because of the effort that it takes to get there. This is a slide that came back from way back in 1966, almost 50 years ago, which shows that the probability of a person attending a health facility drops off exponentially with their distance away from the facility. And we're still having trouble understanding this basic principle that when facilities are few and far between, it's very unlikely that people are going to be able to make use of them, and that's still the case in very poor countries. And so as a result of all of this whole approach to developing child health care services in the community away from facilities became very strong and showed a very dramatic impact, and I'll get into some of this as we move along. So you see here that in 2004, the World Health Organization summarized the very important influences that family and community practices, again outside of health facilities, have on promoting child survival, growth, and development. So this was their review of the current evidence that focused on the importance of community-based primary health care for child health. This is the review that I helped to lead, again focusing on community-based primary health care and child health. And in these slides that follow, you see the very large number of very important interventions that have been scientifically shown to improve health that can be delivered outside of facilities. And I'm not going to go through these. But just for child health alone, the list is quite substantial. The enthusiasm with which these community-based interventions have been taken up in very poor countries has been disappointing, but I think we are seeing more recently expanded interest and rapid growth now in many of these. For instance, the expansion of coverage of insecticide-treated nets is making a dramatic difference in the reduction of cases of malaria, just to give one small example. But recognizing the growing power of community-based approaches to improve health, particularly child health, but increasingly maternal health, and I don't have time to talk about that now, but a number of exciting interventions are coming forth that are very powerful that can be delivered at the community level. And I have mentioned family planning, but that is certainly a very important one that can be delivered at the community level. But this is a framework that came out of some of our work in which we try to highlight the importance of community engagement as well as the healthcare system for impacting health, and the four major delivery processes for providing these interventions at the community level are home visitation, participatory women's groups, what we call community case management, which is diagnosis and treatment by community level workers, and then mobile clinics, which have been the traditional way in which immunizations have been able to achieve their high levels of coverage. So again, I think these are all important as we think about primary health care, and I come back to this concept of John Wyans that I mentioned earlier that's so important. And I mentioned this here to move to this next framework, which I was involved in developing as well, which I think is a nice way of thinking about how we can use community-based primary health care for disease control programs, for basic services, and for addressing the priority needs of communities through these four approaches. So there's increasing interest in community engagement in health systems. It's coming slowly, but the Global Fund to Fight AIDS, Tuberculosis, and Malaria recently has come out with the framework that highlights the need to consider communities and their interaction with health systems, as you see here. The Lancet has recently published an article reviewing the importance of community health workers, which are certainly a fundamental part of community-based primary health care. And there's growing enthusiasm for building up various types of community workers. Interestingly enough, after Al-Mata, there was a strong push towards this direction, but with the failure of Al-Mata, the whole concept of community workers fell out of favor as well, and there were many failures of community health worker programs at that time as well. So we're entering now, after several decades, a resurgence of interest in this, and this slide shows a number of the different types of community-level workers that are used around the world in the implementation of community-based primary health care, and whether or not we can develop these programs and make them effective is certainly one of the key issues in global health today. The ways in which communities can be engaged in community-based primary health care is another important issue. And again, coming out of our review, we see here a wide variety of different ways in which programs have interacted with communities in a way that has led to effective programming for the benefit of children. Let me turn now to a somewhat different kind of framework, which I'm passionate about personally, but is not widely known, and we call it the CBIO framework. It's not specifically a community-based framework, and it's a little more specific than the concept of primary health care at Al-Mata. And we call it the census-based impact-oriented approach, and it grew out of my early days in the early 1980s working in Bolivia, but with the support of John Wyan. And I mention that to bring that link back to those early primary health care concepts that permeate what we have here. So in CBIO, we have a conceptual framework in which a practitioner is working with a population with the overarching goal to improve health and to show that we have, in fact, improved health. But it also recognizes that this can't be done unless a strong partnership between the practitioner and the community has been established. And you can't establish a strong partnership unless you have trust between the health system and the community. And in order to build trust, the practitioner has to respond to community priorities. A very simple set of ideas, but often lacking so much in what we think of as health programming and public health. So you see here some steps that are embedded in this CBIO paradigm, which involves defining the community, that is, determining who's living there, where they're living. That's the census part of this. But making a community diagnosis, which involves determining the epidemiological priorities as well as the community's priorities, which could be very different kinds of things. John Wyan is the person who taught me this idea about epidemiological priorities, and I'm sure he learned it from John Gordon, if you remember from our initial lecture about founding figures in primary health care. John Wyan always taught me that epidemiological priorities are the most serious, frequent, readily preventable or treatable conditions in the population where the program is being provided. And those require technical support to define. A community can't readily define those. But the community's priorities are what they conceive of in their own mind, of course, and they don't require technical support so much. But by clarifying the epidemiological priorities and the community priorities, then the program priorities become a merged set of activities that arise from those two. And so the whole process then builds from that. But epidemiological priorities require some way of contacting everybody in the community, or perhaps at a minimum a representative sample of people in the community. But in the way we have developed this, we have built in routine systematic home visitation as a key action for developing trust with the community, for delivering services, but also for determining what the epidemiological priorities are. So I won't go into that further, but there are a lot of programs around the world that are increasingly using these ideas, and I think it's going to continue to gain steam. And people are developing these ideas on their own without ever having heard of CBIO, and I think there's some real power in them, and I think the concepts are worth mentioning. Another different kind of primary health care, which is also very important now, is what I call participatory women's groups, and there's a special type of this called care groups that I've had engagement with that I thought I would just mention in the outset here. As you see on this slide here, a care group is a group of 10 or so women, and here they're designated as WHEs. WHE means a women health educator. From program to program, different names are given to the women who make up a care group. It's the idea and the principle that's important here. But each one of the members of the care group takes responsibility for 10 to 15 households and the mothers and the children within that household. And over the course of a 2-week period or a 1-month period, she visits all of her 10 households with a specific message. Wash your hands after you go to the bathroom, for example. These are messages that have come out of the community-based IMCI experience, among others. The care group meets periodically, usually every 2 weeks or once a month, with a paid low-level supervisor who herself has been taught this message, and then she carries it to the care group, and then the care group members carry it to each household. So it's a way of achieving very high coverage through a very simple, low-cost process, and the results have been very dramatic. Another interesting element of this, which I like very much, which brings it to CBIO, is the common practice in many of these programs to use these home visits as a way to record vital events, which is a part of CBIO. So recording births and deaths and putting them back into the system is an important way of determining whether you're making any progress with your program. A different approach to this use of volunteer women is shown here in a study from The Lancet, where they did a randomized controlled trial of participatory women's groups in Nepal. And in this case, these were just volunteers from a village who met with a paid volunteer, and this was a very empowerment-focused process where women were encouraged to talk among themselves, to understand their problems, and in the process they also received some education about maternal health issues and neonatal healthcare issues, which is what their study was about. But they were able to show fairly dramatic results in terms of improvement of neonatal mortality through this, and even maternal mortality, which was a big surprise to them. And these participatory women's groups only involved about a third of the community, and so they were spreading this information to the other people in the community to make the impact. And of course, the health impact was determined at the community level, not just among the people who attend these sessions. So finally, let me very briefly mention a different approach to primary health care, which has been very influential, particularly in the United States, but it started in South Africa with the Karks, Sidney Kark and his wife, as shown here in this early publication in 1952. But it is an attempt to involve the community in primary health care, but to a less public health-oriented concept, at least in my thinking. And this was the origin of what is in the United States referred to as the community health center movement. But it's a little bit more of a medical model, but still attempting to engage the community and involve the community, but not so much on public health principles.